Hi, everyone. Thank you for joining us. My name is Donna, and I'm with Genesis Fertility. Presenting tonight is Susanna Conigliaro. Susanna is an IVF clinical coordinator with Genesis. She's going to walk you through the process step by step and answer any questions that you have. I'm going to ask everyone to please hold all your questions until the end of the presentation. But without further delay, I'm going to turn the controls over to Susanna.
Hi, everyone. Thank you for joining. So we're going to go over some information, and like Donna mentioned earlier, please hold your questions until the end, and we'll go over anything that I could possibly help with, okay? So just to get started, I want to introduce you to our doctors. We do have a really great team of doctors, as you can see here, and it would be a privilege to work with any one of them. So some things about our specific clinic. We do monitoring every day of the year. Our doctors do rotate in the OR, so we do have our retrievals actually adjacent to our clinic. And then our embryo transfers are actually done within our clinic. We do our monitoring actually Monday through Friday. We have a bunch of satellite offices open. And then on Saturday, Sunday, and holidays, our Bay Parkway, our main location is open. And that's where you'll be coming to get your blood drawn and also ultrasound. So these are our satellite locations. We have a location in Park Slope, a location in Staten Island, Hewlett, and Queens. But as I mentioned before, Bay Parkway is our main location. This is where your retrieval is going to take place. This is where your transfer is going to take place, and all your monitoring for, like I said, weekends and holidays. And these are some important phone numbers if you want to jot them down. We have our main number, but we also have our IVF phone number. So this phone number is super handy. It'll get you in touch with any of the nurses, just like me and my other colleagues. And if there's anything after hours, there's an emergency, we do have also a service line that you can reach out to us. So before we start IVF, there are some things that we want to take care of, and we can think of them as prerequisites. We definitely want to know a little bit about you. So we want to know through different testing. So we do an AMH level. We do day 3 testing, which is checking your FSH levels. Also, for those with a partner, we do semen analysis to check, if there's any issues there. We do blood work. We make sure that there's nothing out of date. So, like, we also check for your immunity to certain things. We check for hepatitis B, hepatitis C, things that really ideally we don't want to pass on to a growing fetus. We also check your genetics. So we have patients that do screening to check that they and their partner do not have the same genetic disease, that they are a carrier of the same genetic disease. We do a sono-HSG, which is important, especially before transfer, to make sure that there is nothing abnormal in the uterus. If you're starting IVF, one of the things you're going to do, one of your first steps is actually going to be watching modules. Modules are super important. They're going to give you an introduction to your medications. You're going to learn about the process. You're going to learn how to inject yourself, as well as what your medications are. And then after you watch your modules, you're going to have the opportunity to speak with a nurse. You'll be talking with me and some of the other nurses, and we'll go over everything. So it's not as if you're kind of thrown the information and then left alone to absorb it. We do go through everything step at a time. If anyone would need a medical clearance, that's all dependent on the patient. An anesthesia consult, that's all dependent on the patient and their health status. So as I discussed, the modules, they are videos, and there are actually questions associated with some of the videos. So you'll be watching, and then it'll ask you a couple of things to make sure that you're understanding what you're watching. After you watch the video, about 2 weeks later, 2 weeks before your period, you're going to want to make an appointment to speak with one of the nurses. All of our phone pre-ops Everything is done over the phone for your convenience as well. So that way you don't need to take the day off to come see us or, have to make your way all the way to the office. It's over the phone. We go over everything. It's about 15 minutes at most, and we go over all the details of the cycle, as well as an opportunity to ask any questions you might have for us. So starting IVF does have some lifestyle changes that we want to get ready for. One of the big things is cutting down our caffeine consumption. We do allow you to have a cup of coffee a day. That's regular. The rest you can have decaf. Stop smoking. That's super important. We want to minimize our alcohol consumption, especially with the start of injections. And we also try to make sure that there's nothing that you are taking, whether it's an over-the-counter medication or an herbal medication, that is going to have an impact on your stimulation. Also, once you start medications, we need to make sure that you're not doing anything high impact. Your body is going to be actually preparing itself for getting to the point of a retrieval. When you're using your medications, your ovaries are going to be doing work. If you are starting to do exercise during that time, we could have some potential issues later on, especially closer towards the end of your cycle. You can make sure to start prenatal vitamins beforehand, follow a well-balanced diet, and during the time of your stimulation, we highly suggest sticking with Tylenol. I'm not sure if everyone's aware, but Tylenol is actually pregnancy safe, so you can take it during pregnancy. So a little bit about what is IVF. So we use fertility medications to actually um, help the ovaries to produce more eggs. Okay, it stimulates your ovaries. And then once we have those eggs, they're going to be fertilized with sperm in our lab. And that's going to create embryos. Once we have embryos, that's what's going to be transferred back to your uterus. There are different types of fertilization. There's conventional insemination, which actually you can see in the left-handed picture. And then there's 𝗖𝗹𝗋, where actually one sperm is introduced to the egg. Okay. Now, in an IVF cycle, we have the suppression, which may happen. Not everyone will be given a suppression prior to starting. And then we have stimulation. Stimulation is going to be all those injections that we're going to talk about a little bit further in detail. And then after you take your medications, those stimulation meds, you're going to go to your egg retrieval. That's where we're going to actually remove the eggs from the ovary. After that, we're going to do a transfer. And then after your transfer, we schedule for a pregnancy test. So on average, it is about 8 to 12 nights of medication. At our clinic, we ask our patients to call us on the first day of their full flow and then come in on the second day for their baseline blood work and ultrasound. Okay, on day 2, that's when you're going to get a call actually from one of the nurses after the results are reviewed with the doctor. And we'll go into detail about what medications you're taking, how much of the medication you're taking, and when you're coming back. You will come back into the office about every 2 to 3 days for monitoring. And towards the end of the cycle, it might be every day. It really depends on your body's response. So these are a bit of common medications. And like I said, everything is tailored towards your diagnosis, towards your body. So at first we have Lupron. Lupron is medication that's actually started before your period. So you would come in on like a cycle day 21, or if you have a shorter period at some point, you start this medication in your luteal phase. So just a week before your period. Then also we have another version, which is microdose Lupron. That's actually started with cycle day 2. It is a injection which you will take. So the microdose Lupron is actually twice a day an injection, and the Lupron or Leuprolide, that's actually taken in the morning at our clinic. So those are 2 medications. Then we have an antagonist, And these medications are common as well. So this is ganirelix and this is cetrotide. This actually helps to make sure that you're not going to be ovulating prior to getting to your retrieval. Okay, cetrotide comes in a kit. You do have to mix it. Meanwhile, ganirelix does come in a pre-filled syringe, so it's a little bit easier to do the injection because you don't have to measure anything. But they're both subcutaneous. They're both done in the belly or thigh. Now, these are stimulations. So this is Follistim and Gonal-F. These are actually FSH medications. They are also done in the evening. So you're going to inject yourself. They're both pens, meaning that all you need to do is when you get the medication, you're going to get the dosage from the nurse. And let's say she tells you you're going to inject 150 units. All you need to do is turn the dial in the back. I'm not sure if you're able to notice, but on the, especially the Gonal-F, there's a red point in the back. You're able to turn that dial and there's a window with a number. You turn that dial to 150. That's the dosage that they're telling you to take. You put the needle tip on and then you're going to inject in the belly or thigh. It's super easy. How do you know if you got the medication? If you look at the window on the pen, it's going to change from 150 to 0. If for some reason you're doing your injection and you see that from 150 and went down to 50, that means you haven't completed your entire dose. Maybe there's not enough medication in the pen and you need to open another one, or maybe there's an issue with the injection. You can just take off the needle at that point and then try to do the injection with another needle and just make sure, you're taking your full dose of medication because that's what's stimulating your ovaries. Another type of medication is Menopur. Menopur does involve mixing. This is also a gonadotropin, and this is going to actually involve mixing powder and liquid. Now, the dose, each vial of Menopur is 75 units. So the nurse will usually tell you your dosage in vials. So if you hear 150 units is the same thing as saying 2 powders of Menopur. And you always mix this medication with 1 milliliter of liquid. So we highly suggest that when you mix your Menopur, you're only using 1 milliliter and there is extra liquid in the vial. You can actually get rid of that vial because you don't want to keep it for the next day. And then that can cause, issues with if there's bacteria that starts to grow or anything. It's just safer practice to use a new vial of liquid. This is also subcutaneous injection, so you are injecting this in the belly or thigh. And when you mix your Menopur, there's actually a really great, there's these plastic adapters called Q caps. They're really great for mixing, and you will inject yourself with a smaller needle because most of the time the pharmacy will send you your mixing needle and syringe, and that usually has a really long needle, and you don't want to use that. It's very uncomfortable to try to inject yourself with a long needle, especially in the belly or thigh. So, like I said, you're going to be coming in for blood work and ultrasound pretty routinely every 2 to 3 days, every day towards the end, possibly. We do call you with instructions. We actually started rolling out an app that we're starting to use. So our patients are going to be able to see their lab values as well as their ultrasound results, and then also the instructions for medications. So that's a really wonderful resource. Now, when it comes to the end of your cycle, you're going to need to take a trigger. The trigger is the last injection you will take for the cycle. It actually is the last one because it helps with the maturation of the eggs. These can be done either intramuscularly or subcutaneously. There are many different types of triggers. Each one is tailored to your response. So there's Novorel, Pregnil, and actually HCG. Those are all a type of HCG. So they're all one type of specific hormone. And then there's also Lupron, which we discussed earlier. Lupron can also be given as a trigger, especially with patients who are at risk for OHSS. And we'll discuss OHSS a little bit later on. The dosaging, once again, it's all dependent on your response to the cycle. So On the night of your trigger, you're most likely going to discontinue all your other injections. Your partner would be encouraged to eliminate sperm that evening unless there was a reason for them not to. Then the next day after you take your trigger, you're going to come in for blood work to make sure it was absorbed. And then you would be NPO or make sure you have nothing to eat or drink after midnight. One thing I didn't mention is that triggers are very important, the timing. Okay, so the nurse is going to tell you the exact time you need to take your injection. For example, let's say you're to take your trigger at 8 o'clock. That means 8 o'clock. It doesn't mean 8:15 or 8:30 or 7:30. 8 o'clock on the dot. Um, so now you've done your trigger, you've come in for your lab work, and it's the day of your retrieval. You want to make sure you wear something comfortable. You're going to be undergoing anesthesia. You want to make sure you're on time. I don't want you to be stuck waiting for your retrieval to happen if you're late, especially in the morning when there's traffic. You want to make sure you're always on time and you're going to check in at the Brooklyn Surgery Center. So they're actually located on the 4th floor of Bay Parkway. Okay? We want to make sure nothing with a scent, so no perfumes, colognes, powders. We want to make sure no jewelry, no contact lenses. And like I said, NPO meaning nothing by mouth the night before. If you do have even a sip of water that morning, you are at risk for canceling your retrieval. And you've done so much to get to that point. You don't want that to happen. Also, you want to make sure because you're going to be under anesthesia, there needs to be someone to take you home after. Super important. They actually will not even let you into the OR unless you have someone as your escort. So as you're going into your retrieval, your male partner will also be asked to produce a semen sample for the day. And usually, unless there's any other arrangements that are made, that is going to be a sample, a fresh sample. Unless, there's other reasons they're not there, we have a frozen sample, that would be used instead. So we do encourage our patients to use whatever mode is easier for them, especially with their partner. They can either produce at our office or they can produce at home. The sample would need to be in a special sterile container. It would be 1 hour from production. It needs to be in our facility. It should be kept at body temperature. And we ask you to not use anything that could potentially be toxic to the sperm, so especially some lubricants. These are some images of actually how the procedure is done. If you can see in the first one that actually there's a transducer that they introduce into the vagina, and that's how they're taking the eggs out of the ovaries. And then right next to it is actually a picture of the little egg coming out from the follicle. So after the retrieval, you're going to be sent to the PACU, and you're going to be actually there for a little bit until you're able to be assessed, and then the nurses there will then send you home. You should expect some cramping or spotting that's potentially can happen after the retrieval, and we do suggest taking Tylenol. Okay, your retrieval itself is maybe 20 minutes, 30 minutes at the absolute most. After that, you're going to be waiting to be assessed in the PACU, and that can take about an hour and a half, depending on, how you're feeling after you're waking up from anesthesia. So now that you've gone through your retrieval, and now we're going to talk about what happens afterwards. On the day of your retrieval, we consider that day 0, meaning this is the day that the sperm is being introduced to the eggs. We don't know about the fertilization until the next day, which we're going to consider day 1. So on day 1, one of the nurses would actually call you and let you know how many eggs have fertilized. And then on day 5, 6, day 5 or 6, or even 7, this is specifically for PGTA testing. This is testing your embryos for chromosomal abnormalities. And also, some patients might be doing PGTM, which is checking for abnormalities, as well as checking for a specific gene. If if their partner and them actually have the same gene, and then we want to make sure that it's not going to be passed on to their children. We have to make sure we do testing as well. So those tests do take, I know here it says 7 to 10 business days, but as of now, it's looking more like 10 to 14 business days after the samples are sent out. Okay, ideally, we would wait for those results to come back before we start any type of frozen embryo transfer cycle. If instead you're going to do a fresh transfer after your retrieval, you would actually start progesterone the night of your retrieval, and then you would increase to twice a day. There's different types of progesterone. One of them is crenone. It's a gel. It comes with an applicator. You would actually insert vaginally, and then you would want to make sure you move around afterwards. And then the other types, there is progesterone suppositories. So that's the one that's actually in the white picture. They look like little wax bullets, and you actually insert them vaginally as well. You do want to make sure you're laying down at least a half hour after, because the medication would be absorbed best that way. Then we also have the dreaded progesterone and oil injection. This is an intramuscular injection, so it is a bit uncomfortable, but if you ask any of the nurses, we do have some tips on how to make it a little bit more comfortable to do your injection. You would use these, like I said, starting the night of your retrieval. And you would continue this, and then just these are some pictures of like embryo division. So this is how it would look. And then we're going from just a fertilized egg to a blastocyst. And that blastocyst is what we would want to achieve in order to do like a PGDA testing, or like if you were to do a day 5 transfer, you would be transferring a blastocyst. So, as we said, there's either a day 3 transfer or a day 5 transfer. If your embryos are progressing well, we might wait until day 5 when the embryos are a blastocyst. And we just want to make sure that, with your transfer and especially afterwards, we don't want to do anything too stressful or strenuous during that time frame. We also want to make sure we're avoiding like intercourse at that time or anything where you're going to be submerged in water. And that's just an image of like how the doctor actually transfers the embryo. So it is done under ultrasound, and there's a special catheter that's used. The embryo is loaded into the catheter and then introduced into the endometrium. And actually, when you're in a transfer, after they do the transfer of the embryo, you could actually see it. There's like a little bubble on if you watch through the ultrasound. And the actual catheter itself is brought back to the lab, and it's made sure that there's not an embryo still stuck in there, because that's super important. We want to make sure the embryo makes it to its home in the uterus. So, as with everything, there's always a potential things we need to think about, especially with IVF, because it is a medical procedure. It is also involving medications. One of the things that we take into consideration at our office is OHSS, because certain women are at risk for developing OHSS, and we'll discuss that a little bit more in detail on the next slide. If there's a poor response to medications, there might be a risk of cycle cancellation. There's always a chance that embryos may not result, so we never know after a retrieval if fertilization will occur. Okay? We may need to preserve embryos and not proceed with a fresh transfer because of OHSS or because the lining is not ideal for a patient. We also know that IVF itself has an increased risk of multifetal pregnancy, of an ectopic pregnancy, or even chemical pregnancy. So OHSS is ovarian hyperstimulation syndrome. It is noted to be quite uncomfortable. Usually a couple of days after retrieval is when women start feeling the worst part of it. It usually starts with a little bit of bloating, and then that bloating kind of becomes super uncomfortable to the point where you start to feel short of breath because you're just super bloated and feel all this pressure in the abdominal area. With that, we always recommend women to check their weight Okay, that's one way we check to see if you're developing OHSS, if you're urinating less than usual. You can also feel nauseous. You can also have diarrhea from this. Another thing is because, just like an aside, just because you're going to be under anesthesia, a lot of women complain about constipation. So those are just some things that unfortunately come along with IVF. Or now, when do we see that OHSS is something that women need to come into the office and be evaluated? So if you're having issues where you're not being able to urinate, if you have shortness of breath and you're feeling like general malaise and you really just can't get around, like, you will come into the office for an assessment with either a nurse practitioner or one of the doctors. We do try to take steps to make sure that OHSS stays very mild. How can we do that? So before, when we were discussing triggers, a doctor may decide to change your trigger to something that has Lupron in it to help to lower the estrogen level. Another way is we actually give medication to help. After the retrieval, you might start it like right after your trigger or the day after of your retrieval. It is a medication that by mouth, actually, it's a pill that you would take for 8 days, and that can help. And basically, you want to just watch out. If you're feeling great, but you're feeling bloated, we would still recommend to, take caution and make sure that it's not anything that's going to become worse over the next couple of days. Now you've had your retrieval, you've had your transfer, and now you're going to come in for your pregnancy test. This is a very big day. It is 2 weeks after your retrieval, and we do get really excited to call our patients with our pregnancy test. We always hope to call patients with a positive, and we know that's not always possible. So when you do have a positive test, we do repeat the test until about a beta HCG level of 1,000. um, our negative test results, we would have them stop medications. And unfortunately, at that point, they would start a bleed or a period. Um, Once you're at 6 weeks, we would do a scan for to make sure for gestation. And then 8 weeks of gestation, we would do another scan. So we would say around 8 weeks to 12 weeks, you would actually graduate from our clinic to your OB. But up until then, you are in our care. So if there's any issues, you can always feel free to give us a call. Especially the nurses, we're in the office. We're always taking phone calls, emails, making sure our patients are always taken care of. These are some important websites. I think Donna will probably put up the websites later on. It's great resources. I would say the best resource from here is probably the Freedom MedTeach and the Menopure.com, especially the Menopure.com, because it is a really great resource video for people who are doing their medications for the first time. Especially Menopure can seem a little bit daunting, given the fact that it needs to be mixed. And there's a really great video. You watch it once or twice, and then you're set to go. That's a lot of information, and I know there's probably some questions, so I'm ready to open up the floor if there's anyone who has any questions that I can help.